We're going to do today the trunk and thorax anatomy. Can you tell me what is the origin and insertion of external oblique muscle?
So external oblique muscle uh, from the front of lower eight uh, ribs, and it gets inserted on the xiphisternum, then linea alba and pubic symphysis.
What are the direction of fibers?
It's downward, forward, and medially.
Okay, and what is the nerve supply?
Intercostal nerve from T7 to T11.
You could have mentioned as well the anterior half of the outer border of the crest and T7 to 212. I mean, you said subcostal nerve and T7 to 11 and downward, forward, and medial. What is the origin and insertion of the transversus abdominis muscle?
It's from the lower six ribs, then thoracolumbar fascia, anterior two-third of iliac crest, the middle part, and lateral one-third of inguinal ligament. It gets inserted on the xiphoid process, linea alba, and pubic crest.
Yeah, and also the conjoint tendon as well. And what's the nerve supply for this muscle?
The intercostal nerves T7 to T12, subcostal nerve, and I think iliohypogastric nerve.
Yeah, branches from the lumbar plexus, you're right, iliohypogastric. What is the direction of fibers?
It's from lateral to medial, transverse.
Yeah, transverse fibers. Okay. And can you tell me about the openings of the diaphragm?
So we have three openings at T8, T10, and T12. T8 we have vena cava along with the phrenic nerve. Then T10 is esophagus along with the vagus nerve, and some branches from the esophageal artery, esophageal branches from thoracic aorta. Then the third is the aortic opening. It's T12. It's accompanied by azygous vein and a thoracic duct.
Yeah, so T12 will be the azygous vein and also aorta and the thoracic duct. And what are the attachments of the diaphragm?
It's attached to sternum, and the posteriorly it's attached to the right crust is attached to the vertebra L1, L2, L3. Left is L1 and L2. Then the lower four ribs and the sternum in front.
I don't like the answer, to be honest. It's so basically the attachments you can classify to origin and insertion. All right. So the origin could be a coastal origin and a vertebral origin as well, and the sternal origin. Right. So the
Okay.
sternal origin is coming from the
So
xiphoid process, the lower end of the sternum, and the coastal origin it comes from the lower six coastal cartilages, and the vertebral origin, like I said, is going to take from L1 to L3 on the right and L1 to L2 on the left. There is also the median arcuate ligament, which is right there between the two crura, and the medial arcuate ligament between the body and the transverse process, and the lateral arcuate ligament between the transverse process and also the 12th rib. All right, so these are the origin. You can think about it again. So it's taken the whole section of the abdomen. There's vertebral origin, coastal origin, sternal origin. You know the coastal origin, lower six ribs. Vertebral origin is the most complex. So you want to start by the two crura, the median arcuate ligament, the medial arcuate ligament, and the lateral arcuate ligament. All right. The insertion, they all go into a central tendon, the white structure that you can see here. So they all inserted into the central tendon. And what is the nerve supply of the diaphragm?
phrenic nerve C234 345. Sorry, C345.
Is that everything you know about the nerve supply?
The
Is there
central
any
portion
other
is
nerve supply that
supplied
you
by
know?
the central portion is supplied by the phrenic nerve 345, and the peripheral part is supplied by the intercostal nerves T5 to T12.
Amazing. So now you know the answer. What is the clinical significance of that?
So any irritation to the phrenic nerve, I mean to the diaphragm, the central part of diaphragm, the patient will have a referred pain to the left shoulder, tip of shoulder, because the same nerve supply is by the supraclavicular nerve that has the same root value.
Well, yeah, you can say a little bit more in this area. So basically, like I said, irritation to the central part of the diaphragm, the pain will be referred to the shoulder, but irritation to the peripheral part, the pain will be a little bit more localized rather than referred pain. Okay.
Yeah.
Fine. What's the blood supply of the diaphragm then?
It's a superior and inferior phrenic artery, that is the branch of descending aorta, I mean. Then the musculophrenic branch from inferior phrenic artery.
Okay. Superior and inferior frame from the aorta, musculophrenic, and also small contribution from the intercostal branches. Thank you very much. The only advice I would give you, Amna, is I know you're trying to be quick in your answers, but you need to sort of stress on the main points. Okay, so
Yeah.
you're speaking in a sort of in a certain tone, monotonous. So you wouldn't really specify what are, like, just try to, you know, have sort of intonation or maybe tonation in your speaking. So basically, started by saying, well, if we're talking about the diaphragm, so say, well, initially the origin is, and then start talking about the origin, and then insertion is, and then talk about insertion. So
Okay.
basically, signpost or try to tell me what you're talking about. Otherwise, the examiner can get lost and lose track. Can you please identify number 2 in this one, if that's okay?
Number two will
Christopher,
be
before you start answering, you usually have an issue with your microphone, and you know how to sort it out. Can you sort it out, please?
yes,
There
sure,
is an
sure.
echo in your sound.
Is it fast enough?
Yeah, it's a little bit better. So what's number 2?
So number two will be it will be the celiac trunk.
Okay, lots of unnecessary things here. So you started your answer. So number 2 will be, and then lots of R sound, and then you say the answer. We don't want that in the exam. You just want you to say the answer. All right.
Yes, celiac trunk.
What's number 2? If you don't know
Celiac
the
trunk.
answer, if you want to think about it, just stay silent. All right. Don't say anything, and then say celiac trunk.
Okay.
Okay. So
Yeah.
number 2 is celiac trunk. Can you tell me what is number 3?
Three will be
No, don't do that again. All right.
yeah,
Just
the common
stay silent.
hepatic
Think about it. Common hepatic artery. What is 25?
splenic artery.
Okay. Amazing. And what is 11?
11 uh, this is esophageal branch of the left gastric. Sorry, the left gastric artery.
Are you reading it? So I think
No,
I
not
think
in
the
the,
answer here
no,
is
not in there.
actually accurate, because I'll show you the answer now. It's something that I needed to change in my system. So when I do that, I mean, this should have changed really, but I'll change it later on. So this is basically, you're talking about left gastric. These are not the esophageal branches. Esophageal branches would be number 22. Okay.
Okay.
So I just need to change this. So obviously 12 is not the quadrate lobe, because quadrate lobe is 23, isn't it? So I just need to change the numbers, all right? So ignore the numbers for now, but what we said is 2 is celiac trunk, 3 is common hepatic, 25 is the splenic, and 11 is
Left
the
gastric.
gastric artery. All right. So I just need to change these numbers. Fine. As you can see here again, this is the gut supply, celiac trunk, left gastric artery, splenic artery, and also the common hepatic on the other side. These are the main things to understand here. Moving forward on this one, I want you to identify. Let me just do that again, so you wouldn't see the answers. Yeah, and this one I want you to identify number 29 and number 30. That's right.
29 is the superior mesenteric artery, and 30 is the superior mesenteric vein.
Amazing. I really like that. You stayed silent. You didn't think out loud. It looked very confident. You took your time. That's great. Always do that. All right. Okay. What is 19 then?
19 is the body of the pancreas,
Okay. 20.
head of the pancreas.
Amazing. 17.
right edge of right lobe of the liver,
Right lobe, yeah. Make it simple. 15
left lobe of the liver,
and 25.
the spleen,
Yeah, 25 is the spleen. And what about number 6?
falciform ligament,
Well done. Well done. And moving forward from here, what is 1 and what is 10?
1 is the abdominal aorta, 10 is the inferior vena cava.
Amazing. And what is 7?
I'm looking for 7.
I'm pointing to it.
Oh, sorry. That is the body of the gallbladder.
Yeah, amazing. Well done. 25 is the spleen. It's the same diagram, basically, but we reflected the pancreas with the mesentery as well to see the underlying structures. So 1 is the abdominal aorta, 10 is the inferior vena cava. And what about number 5 on this one? Again, pointing to it.
1 second, I'm just trying to zoom in. That is the inferior mesenteric artery.
Inferior mesenteric artery, I agree with you. And you have all its branches here. You have number 6 as.
That is the left colic artery.
And what about 14?
The sigmoidal artery.
Sigmoidal branches. And also, what about 17?
The superior rectal artery.
Amazing. Well done. I like that. Thank you, Chris. We'll do like some sort of quick questions just to ask everyone. Maybe we can take next Sad. Okay, let's do abdominal aorta. Can you tell me what is the surface anatomy of abdominal aorta?
This surface anatomy. So it starts from T12 and until the L4.
How would you find the T12 by surface anatomy?
The transpyloric plane. And
So that's
L4.
what I want to hear, right?
Oh, fine. Yeah. Okay.
Yeah, keep going. The answer is
okay.
not done yet.
Yeah, so the abdominal aorta, it runs from T12 to T4. T12 is in the transpyloric plane, and L4 is in the intercostal plane.
That's still not correct, right? So are you sure that T12 is at the transpyloric plane? So no, right? So it runs from T12 to T4, but this is not surface anatomy. Okay, that's not surface anatomy. T12 to T4 is not surface anatomy. So T12 is basically it's 4 centimeter above the transpyloric plane. The transpyloric plane is usually at the lower border of L1. So you want to go 4 centimeters above that. Okay, and you want to go to L4. L4 is in the transcrestal, between the iliac crest, all right? Transcrestal plane in the midline. And the you basically, the aorta is connecting those 2 points. But still, you're talking about the transpyloric plane as if it's a very clear anatomical landmark. It can be clear, but it's not like the nipple line. If I say the nipple line to you, you know where it is because everybody has an obvious nipple that you can identify the nipple line. But not everybody has a certain landmark on their skin to identify the transpyloric plane. The transpyloric plane, you still need how to find it. It's halfway between the suprasternal notch and the pubic symphysis. So you can easily find the suprasternal notch and you can easily find the pubic symphysis. So it's the halfway between them, all right?
Yeah.
So it's basically the middle half. You deduct 1/4 up and 1/4 down. So the middle half will be, exactly the halfway will be the transpyloric plane, and the middle half among them will be the aorta. Okay?
Yep.
All right, so T12 to T4, you need to say how to find T12, 4 centimeter above the transpyloric plane. You need to say how to find L4, the transcrestal plane, and you need to say how to find the transpyloric plane. And this is halfway between the suprastellar notch and also the pubic symphysis. In the halfway, you will find the transpyloric plane. What are the branches of the aorta? And I need you to think for a second before you say your answer, and just to try to get a very good classification, or an easy way to remember the branches of the aorta.
So the aorta has posterior branches, anterior branches, and lateral branches. The posterior branches are initially are the inferior phrenic arteries. Another posterior branch are the lumbar branches. The last one is the median sacral artery. The lateral branches include the suprarenal artery, the renal artery, and the gonadal artery. The anterior branches of the aorta are the celiac trunk, superior mesenteric artery, and inferior mesenteric artery.
Well done. So from anterior surface, the three major gut supply: lateral side, inferior phrenic, middle suprarenal, you didn't mention that, and renal arteries, posterior branches, lumbar, gonadal, and median sacral. I think you said the phrenic has a posterior branch. There is a lateral branch instead. And terminal branches, obviously, we tend to forget that because they're the most common branches. The two common iliacs are the most important. I would mention them at the beginning, all right? Cool.
Do
and
we have
also,
to mention the levels as well, like which level the branches
not
are coming
necessarily,
off?
unless you're asked. I wouldn't necessarily mention them unless I'm asked for them, right? This is actually
Okay.
another classification that you can do, right? So you can say, starting from T12, we have this and this. L1, we have this, and L2, we have this, and you work your way down, okay? So you can do it by levels if you're happy with that. So maybe you can say L1, celiac trunk, middle suprarenal, L2, superior mesenteric artery, L3, inferior mesenteric artery, etc., etc. All right, so you can do it by levels, or you can do it by the surface, which I found the surface a little bit easier, and you can still know the levels as well, but I wouldn't necessarily mention them unless I'm asked. Okay, so
Yeah.
in this one, okay, just very quickly, we're gonna revise the branches. What is A?
The abdominal aorta.
Yeah, I think it might be pointing to the celiac trunk really, but it's fine if you say abdominal aorta. It's quite confusing, to be honest. What is F?
The splenic artery.
Amazing. G?
The common hepatic artery.
I?
The gastroduodenal artery.
J?
Left hepatic.
K?
Right hepatic.
Artery, of course. And
Yeah.
what is E?
E is the right renal artery.
And D?
Left renal artery.
And H?
Superior mesenteric artery.
And L?
Inferior mesenteric artery.
And C and B?
Left common iliac and right common iliac.
Well done. And what is the abnormality in this scan?
There's an aortic aneurysm.
Yeah, you want to say infrarenal because you can see the kidney here. Infrarenal abdominal aortic aneurysm, right?
Okay.
And also specify this is an abdominal aortic aneurysm because you obviously you have thoracic aorta and the arch as well.
Yeah.
Okay, what is an aneurysm then?
It's abnormal localized dilatation of a blood vessel.
Yeah, and what is the pathogenesis of that?
So basically it's the loss of the intima of the artery, and there's also loss of elastin from the tunica media of the artery. This leads to weakening and dilatation of the vessel wall.
Yeah, well done. That's the one that you want to say. You can say median cystic necrosis, but the cystic necrosis doesn't happen with every case. So it's mainly the loss of intima and loss of elastin, which pretty much happens with every case. And what are the causes, the general causes of an aneurysm?
So the causes of an aneurysm, they can be congenital, So a hereditary structural defect. There could be inflammation, for example, vasculitis because of an autoimmune disease. There could be an infective cause, for example, syphilis infection. It could be because of sustaining trauma. Other general risk factors include smoking, high blood pressure, alcoholism, diabetes, cholesterol.
Yep. So yeah, well done. I think you said all the answer. Very well done for that. The only thing that I would avoid, and I keep saying to every candidate, I know it sounds a little bit boring to every time say that, but basically try to avoid using fillers in your answer. The examiner will see lots of candidates on that day, especially in your afternoon exam. They wouldn't be really focusing, and they just want to hear the right words to give you the mark, and that's it. Just make it simple for the examiner. So I would say congenital, traumatic, inflammatory. You mentioned the main things, and the most common one is atherosclerosis. I would avoid using words like, well, the causes of aneurysm could be, and another thing could be, and then could be, and might be. I would avoid using all these fillers. Just say the answer very directly. Okay, what is a dissecting aneurysm?
A dissecting aneurysm is separation of the layers of the arterial wall with propagation of the dissection both proximally and as well as distally.
Yeah. So yeah, it's mainly the separation of layers with propagation proximally and distally. So thank you very much. I'll move on to another candidate. Thank you, but well done.
Thank you.
I think that's my last comment, is the only comment about your performance, really, but otherwise, very well done. Okay, can you tell me the tributaries of the inferior vena cava?
So at the bottom we have the common iliac veins, and it forms the inferior vena cava. And we can have the lumbar veins, renal veins, suprarenal veins, and also the testicular veins. These are all paired, and hepatic vein, as well as the paired inferior phrenic vein.
Yeah, well done. Okay, in terms of renal vein, what is the anterior relation of the renal vein?
So we have the right side as well as the left side. On the right side we have the duodenum, the second part of it, and on the left side we have the superior mesenteric artery, the body of the pancreas, as well as the splenic vein.
Yeah. So yeah, well done. Right, second part of the duodenum, left side, SMA, splenic, and pancreas as well. Cool. In terms of esophagus, we have a few questions about esophagus. Where does it begin?
At the, I remember, C6, I
Inferior
think.
border of C6, and it ends at T11,
Yes.
right? Okay, what's the blood supply of the esophagus?
Okay, so the lower part of the esophagus is supplied by the left gastric artery, and the middle part of the esophagus is supplied by
It's fine. So for the general answer here for any blood supply, I want to say arterial blood supply and venous blood, or a venous drainage. Okay, so for the arterial, you have upper third, inferior third artery, middle third, aorta, the thoracic aorta, and also the lower third is the left gastric from the celiac trunk. The venous drainage will follow the arterial, but you still want to mention it. Okay, and it will go to the brachiocephalic, the azygos vein, and also the left gastric to the portal vein. Okay, what are the lymphatic drainage of the esophagus?
I don't think I can remember.
That's fine. So lymphatics will be upper third, deep cervical lymph nodes, and middle third to the mediastinal lymph nodes, and the lower third will be the gastric lymph nodes. Okay. All right. There is something called muscularis externa in the esophagus, and usually in the upper third, it's formed of a striated muscle. In the middle third, it's formed of a smooth and striated muscle. In the lower third, it's formed of purely smooth muscle, right? So basically the striated, something that you can have some control on it. And the smooth muscle, obviously, you don't have any kind of control on it. What is the mucosal lining of the esophagus?
It is a non-keratinized stratified squamous epithelium.
Yeah, and what is a Barrett's esophagus then?
Barrett's esophagus is when, due to irritation of the keratinized epithelium, there can be metaplasia of the cells into cuboid, I think.
So we don't want you to think, we want you to know, right? So the answer here
Oh.
is a metaplastic or metaplasia from stratified squamous to a simple columnar epithelium. Yeah, simple columnar epithelium from stratified. Okay, and what is achalasia? How would you define achalasia?
Achalasia is a motility disorder, and it involves the lower esophageal sphincter. So we can have incomplete relaxation of the sphincter or increase in the tone, and also lack of peristalsis of the esophagus. And it is associated with the development of squamous cell carcinoma.
Not quite. I don't think that it's necessarily related to squamous cell carcinoma. But
Okay.
the definition, just make it simple. It's a motility disorder of the lower esophageal sphincter that leads to incomplete relaxation of the lower esophageal sphincter. And it's characterized by increasing the sphincter tone and lack of peristalsis and loss of the sphincter relaxation, like you said. Microscopy, you will find that you'll have hypertrophy or the musculature with absent myenteric plexus. These plexus are basically nervous plexuses that control the relaxation and the contraction of the lower esophageal sphincter. So given that they are hypertrophied, this will lead to continuous contraction or lack of relaxation of this muscle. What are the sites of esophageal constrictions?
There are three structures that causes this constriction. We have one from the aortic arch, the left main bronchus, as well as the left atrium.
Yeah, the way I would like to remember it, it's CAABD. So you want to say cricoid cartilage, arch of the aorta, left atrium, left bronchus, and diaphragm. What are the complications of esophageal perforation?
Complication of esophageal perforation, of bleeding, as well as
Lots of things. The main thing you want to say is
infection.
well, not necessarily. You will have something called mediastinitis, which is basically the irritant secretions and mucus will come into the mediastinum, leading to irritation and inflammation, so lead to mediastinitis. What is the last rib that you can feel in the mid axillary line?
The 11th rib.
Yeah, that's the 11th rib. All right, Amna, can you identify in this structure? I'm going to tell you a few numbers. What is number 2?
Body of stomach.
Okay, and what is number 11?
Lesser curvature.
And what is number 6?
Fundus.
18.
Pyloric antrum.
19.
Pyloric canal.
And 23, excuse me.
First part of duodenum.
Well done. And what are the parts of the stomach that you just mentioned? You mentioned fundus, body, and the pylorus, right?
Yes.
What is the blood supply of the stomach?
On the lesser curvature, we have left gastric artery, that is a branch of celiac trunk. Right gastric artery, which is branch of common hepatic artery. Then on the greater curvature, we have left gastroepiploic artery, which is branch of splenic artery, and right gastroepiploic artery, which is branch of gastroduodenal artery, and some short gastric branches from splenic artery.
Yeah, so you always forget the venous, right? So a few things, the main tips in anatomy, when you see any dissection, you always say this is, where are you? So let's say I'm showing you left foot. So you want to say at the beginning, this is a dissection of the left foot, and then you start answering, okay? The other thing, any question about blood supply, you want to always say arterial and venous without even thinking, and then start filling the gaps. Any question about nerve supply, you want to always say sensory and motor, okay? So these are general things to look for. So venous drainage as well. I know it follows the arterial drainage. It's a bit boring, but you still want to say it. Okay.
Yeah.
So in terms of the duodenum, what is the peritoneal coverage of the duodenum?
So only the first few centimeters of first part of duodenum is intraperitoneum, while the rest is retroperitoneal.
Yeah,
And
so it's only the first part, yeah. I think, yeah, you said the answer. There's nothing else to say, really. What's the blood supply of the duodenum then?
so it's a superior pancreaticoduodenal artery, which is branch of gastroduodenal artery, and inferior pancreaticoduodenal artery, which is branch of superior mesenteric artery, that is arterial blood supply. The venous is that it follows arterial and it drains into superior mesenteric vein and the portal vein.
Yeah. So you always want to say the branches from the hepatic artery as well, like right gastric and right gastroepiploic. And you want to mention specifically the superior pancreaticoduodenal and the inferior pancreaticoduodenal and the supraduodenal artery from the gastroduodenal arteries. Okay. The relation of parts, I think it's a very long question. It doesn't usually come, but at least mention to me what are the relation of the first part of the duodenum.
I'm not sure about the relationship of duodenum. So I'm not.
So
with
the
this one.
relation, so you have anterior relations, and that would be related to the quadrate lobe of the liver and the gallbladder. Posterior relation, and that would be the portal vein, gastroduodenal artery, and CBD, the common bile duct. I mean, it's rational. So you know that you have the pancreas, and
Yeah.
trying to come out, the ducts, or the ducts are coming down from the liver to it. So you have the portal triad basically, portal vein, and not really the portal triad, but gastroduodenal artery instead, and also the common bile duct. And it makes sense that the gastroduodenal artery is behind the first part of the duodenum, because there is a risk of, perforation and leading to, due to the ulcers and leading to significant bleed. All right. The superior relation obviously is very important because you do have the epiploic foramen, which is the entrance to the lesser sac, and that's an important question that will come later on. All right. That's why I like to always ask the first part of the duodenum, because this is the main area. Okay, there is something called the major duodenal papilla, and this is basically where the major pancreatic duct enters the duodenum in the second part
Part
of
of
the pancreas, the duodenum, sorry. All right, so in terms of the spleen, what is the blood supply of the spleen?
It's from the splenic artery, which is a branch of celiac trunk.
I want to say wrong because we agreed earlier, like a few minutes ago, that you want to
Yes,
always say
and the venous.
arterial and venous, right?
Yes.
So what's your arterial?
Arterial is from the splenic artery, which is branch of celiac trunk. The venous drainage is by splenic vein that drains into that combines with superior mesenteric artery to form the portal vein.
Well done. All right. Okay, moving forward here, you have this is obviously the spleen. Can you tell me what are the structures from A to D?
So A is impression, is the renal impression. B is the colonic flexure and splenic flexure of colon. C is the gastric, the fundus of stomach. D is tail of pancreas.
Yeah, well done. So D is the tail of pancreas, renal impression is A, and C is gastric or the fundus, and B is the tail of pancreas. Sorry, the B is the splenic flexure of the colon. What are the related ribs to the spleen?
9, 10, 11.
Yeah, and what are the structures to worry about if you're doing a splenectomy?
Injury to tail of pancreas.
Yeah, mainly the tail of pancreas. And what is the course of the splenic artery?
Splenic artery originates from a celiac trunk and it transfers over the superior border of pancreas and it ends into the lienorenal ligament which ends into the spleen. It's a tortuous course.
Just make it simple. Celiac trunk, tortuous course above the pancreas, right? And ends into the hilum, passing through the lunar ligament, right? That's it. So just 4 points. Is the spleen normally palpable or not?
No, no. If it's
And
size, then only it can be palpable.
yeah, double its size. Okay, fine. What's the clinical significance does this have? Knowing that it's double its size. No, sorry. What's the most dependent part of the abdomen?
It's the Morrison's pouch. It's the right infrahepatic pouch.
Yeah,
Paragon.
so the right paracolic gutter instead. That's the Morrison's pouch. And what's the clinical significance of that?
So it is the most dependent part in supine position, and all the collections can get collected and form an abscess here.
Yeah, that's right. And also, if you're doing a midline laparotomy, can you tell me the layers that you're going to go through?
Skin, subcutaneous fat, then scarpa's fascia, linea alba, transverse salis fascia, and intraperitoneal peritoneal fat.
So yeah, you said skin, and then
Subcutaneous
subcutaneous
fat,
scarpus
scarpa,
fascia,
linea alba, transverse salis fascia.
transverse, and extraperitoneal fat. Okay, that's fine. And then maybe we can do. We're gonna come back to you anyway, so maybe we can take next. Maybe identify what is A and B.
A is the right lobe, B is the left lobe.
Yeah, and also what is C and D?
C is the quadrate. No, sorry. C is the caudate. No, sorry. C is the quadrate, and D is the caudate.
I heard one thing. I heard caudate in C and D. Can you say again?
D is caudate, and C is quadrate.
Okay. So which side is inferior? Which side is superior?
The inferior is the quadrate lobe, and superior is the caudate lobe.
Okay. So can you point to C and D? Which one is inferior? Which one is superior?
D is superior, C is inferior.
Okay. So you're talking, yeah, obviously this is gallbladder, so that's inferior. What's the lobe that's very close to the gallbladder?
Quadrate.
Quadrate lobe. So this is quadrate lobe and this is caudate lobe. Okay.
Yeah.
Fine. E, we said it's gallbladder. We have 3 structures here to identify: I, K, and J.
I is the common bile duct, J is the portal vein, and K is the hepatic artery.
Okay, what about F?
F is the inferior vena cava.
And also what about H?
Is the ligamentum teres.
Yeah, so ligamentum teres, and also you have ligamentum flavum will be, or sorry, the falciform ligament will be sort of G, the continuation. Okay. Yeah, so this is ligamentum teres. So it's very important to take a second and look into this and try to identify. Think about multiple questions that can be asked here. You can be asked about the relation of the gallbladder to the liver. Okay. You can be asked about basically the relation of the vena cava to the liver as well. You can be asked about the structures in the hilum of the liver. And you can be asked about the loops of the liver. So the loops, do you know how we classify the loops of the liver?
With like the fossa of the gallbladder and the inferior vena cava.
I want
like
to hear
right
2
and
key
left.
things.
Oh, so it can be
when
divided
I ask you,
structurally or functionally.
yeah, perfect.
So
All right.
so surgically, it's the right and left lobes are divided by the inferior vena cava and the fossa for the gallbladder, and anatomically it can be divided anteriorly by the falciform ligament and posteriorly by the ligamentum teres and the fissure for the ligamentum venosum.
Perfect. All right. So that's what I want to hear. So functionally and structurally. Okay.
Yeah.
Well done. So these are the questions that can be asked. If you keep looking at the diagram, you can get many questions. So basically, this is the inferior border. You can talk about the quadrate loop and also its relation. and also the caudate lobe and its relations as well, inferior vena cava, etc., etc. So just take a minute to look at it. Well done. In terms of, there is a very similar diagram here. I'm just going to ask you very, very quickly. 9 is?
Gallbladder.
And 21?
Quadrate lobe.
2?
Caudate lobe.
20?
The hepatic artery.
Is it an artery or a vein?
Oh, sorry, it's the portal vein.
Portal vein, because it's a squishy and very thin, that looks like a vein, right? And
Yeah.
then you have 11,
The hepatic artery.
5,
Common hepatic duct.
yeah, I agree, and 23.
The omentum, covering
What
the
is
porta
the omentum?
hepatis.
Yeah, so you want to say this is the porta hepatis, basically. Okay. And obviously the lesser omentum will be attached to it. And 16?
Fissure for ligamentum venosum.
Okay, so that's ligamentum venosum. And 13?
The inferior vena cava.
Well done. And I think maybe 17.
Falciform ligament.
Falciform ligament.
I'm sorry, someone's trying to answer.
Oh, I said
So
falciform ligament.
I know
think,
you said, but
oh.
I'm just going to the other person who's trying to, but I'm not sure who. But please stay mute if you're not being questioned. That's fine. Yeah, we talked about what separates the right and left liver anatomically and functionally or surgically. And we talked about the boundaries of the quadrate lobe. Basically, I think we said it's one of the potential questions. You can just look at the diagram, say, right gallbladder, falciform, and also the porta hepatis superiorly and the inferior border of the liver. We said the structure in the porta hepatis. And if you have a stab in the epigastric region, what organs that can be affected?
The left lobe of the liver and stomach.
Well done. And what's the blood supply of the liver?
So the arterial supply is by the hepatic artery proper and the portal vein, and the venous drainage is from the hepatic vein to the inferior vena cava.
Yeah. So the portal vein, basically 75% of the blood supply. It's a partially deoxygenated blood, but that's the main blood supply of the liver. So well done. And like I always said, you can always classify arterial and venous, which I think you did. Okay, the ligaments supporting the liver, we said falciform ligament, ligamentum venosum, ligamentum teres. You can add to that coronary ligaments as well, and also the triangular ligaments, all right? But we said most of them anyway. Okay, what is callus triangle and what are the boundaries and the contents of this triangle?
The superior boundary of the Callot's triangle is the inferior surface of the liver. The medial boundary is the the common hepatic duct. The inferior lateral boundary is the cystic duct, and the contents include the cystic artery, right hepatic artery, and the portal vein.
Yeah, so these are the boundaries. This is just diagrammatic representation. Inferior border, cystic duct, and common hepatic duct, and it contains mainly the cystic artery. That's what you want to mention. And the clinical significance of that. Do you know the clinical significance?
When performing a cholecystectomy to avoid injury to the cystic artery and portal vein.
Amazing, yeah. So you want to identify this triangle before resecting anything to make sure that you don't injure the hepatic artery or the cystic artery. Okay, we talked earlier about the epiploic foramen. Remember when we talked about the relations of first part of the duodenum? We said anteriorly we have some structures, posteriorly we have some structures, and superiorly we have the epiploic foramen. All right. So can you define to me what is epiploic foramen?
The epiploic foramen is the entrance to the lesser sac. It is bounded by the inferior vena cava, the first part of the duodenum, the caudate lobe of the liver, and the inferior vena cava.
Is it caudate or quadrate lobe?
The caudate.
Yeah. So it's caudate lobe in the inferior border of the lever, and inferior vena cava, like I said, and also the lesser omentum or the free border of the lesser omentum. Okay, what are the structures inside the free border of the lesser omentum?
The hepatic artery, portal vein, and bile duct.
Yeah, well done. Okay, so there is a maneuver that we're trying to do here. Do you know the name of that maneuver?
This is known as the Pringles maneuver.
And what's the clinical significance of that?
When there's a liver laceration to prevent hemorrhage or bleeding, this Pringles maneuver is performed.
Yeah, well done. So, and obviously, you know the structure is being compressed or being, squeezed, and these are the portal triad, which we mentioned here: portal, vein, CBD, and right hepatic artery. We said the clinical significance.
Gallbladder is situated in the transpyloric plane, and the junction of the transpyloric plane and the right midclavicular line would be the stiffest anatomy of the gallbladder.
Yeah, so well done. So that's actually a surface anatomy structures. You can say it differently, that it's at the tip of the 9th costal cartilage and the mid clavicular line. However, the 9th, clavicular costal cartilage, it might be tricky to know it, but you can also get it from suprasternal notch. Identify the spaces until you count to 9, and that would be the gallbladder, or the transpyloric plane in the mid clavicular line. So well done. Okay, what are the causes of shoulder pain in cholecystitis?
In cholecystitis, there may be the perfusion of fluid retroperitoneally to irritate the central portion of the diaphragm, irritating the phrenic nerve, and the phrenic nerve shares the same dorsal root as the subscapular nerve. So therefore, it can be
Supraclavicular nerve, you mean?
clavicular nerve.
Supraclavicular nerve, you mean? That's what I mean. Supraclavicular, not subscapular. All right. So so we've done a study here to identify the structures of the biliary tree. So what is this study called?
It's an endoscopic retrograde cholangiopancreatography.
Okay. What is
scan.
B?
It is the pancreatic duct,
What is C?
common bile duct,
G?
the stick duct,
H?
common hepatic duct,
And A?
the duodenal papilla,
Or ampulla ovata? Ampulla ovata, right? So A is the ampulla ovata, not the duodenal thing. Okay. All right. So I mean, obviously we said that before, but where does the common bile duct enter the bowel?
the duodenal papilla, which is just posterior medially within the junction of the end of the first part of the duodenum and the beginning of the second part of the duodenum.
A different way to find it. It's in the second part of the duodenum, but it's 10 centimeter from the pylorus. You walk your way 10 centimeter from the pylorus, and you'll find it at the posteromedial part of the duodenum. Okay. Anatomical structure that controls bile secretion.
Sphincter of Oddi.
Yeah, sphincter of Oddi. Well done. In terms of pancreas, what are the cell groups of the pancreas that you know?
Well, we have the endocrine cells, which would include the cells, the alpha cells and the beta cells, secreting glucagon and insulin, respectively. You also have exocrine cells, which would secrete proteases as well as lipases. There are also cells that contain somatostatin. I can't remember the name of the cells.
Delta. So it's alpha, beta, and delta, right? Alpha, beta, and delta. These are the cells. Okay. Blood supply we mentioned before, but do you mind summarizing it to us?
So summarizing, you have the arterial and venous supply. So with the head, the neck, and the uncinate process. It's arterially supplied by the superior, anterior, and posterior pancreaticoduodenal arteries, which is a branch of the gastroduodenal, inferior, anterior, and posterior gastroduodenal arteries, which comes from the superior mesenteric artery. The arterial supply of the body and the tail comes from the splenic artery. And with the venous supply, there's the body and the tail is from the splenic vein, and the head and neck it drains into the superior mesenteric vein, which then goes into the portal vein.
Yeah, well done. That's actually a perfect answer. I maybe need to rewrite mine. Yeah, well done. Arterial and venous, like we agreed before, and then you classified it by the parts of the pancreas. So yeah, well done. Okay, what are the vessels ligated during Whipple operation?
In a Whipple's operation, we will be okay. So in a Whipple's procedure,
Let's start by vessels encountered first. What vessels do you find or do you meet during Whipple's procedure?
will be encountering the splenic artery or the celiac trunk. We'll be encountering the splenic vein, the superior mesenteric vein. We'll also be encountering the left
Basically,
renal.
almost like all the vasculatures in this area. You'll see the aorta, superior mesenteric artery, celiac trunk. Maybe you wouldn't go that high, but you can. I think you can say it. Pancreaticoduodenal artery. In terms of veins, SMV, splenic vein, and portal vein, because they're formed this way, and also the left renal vein you can face as well. Which one do we ligate? I think you will find different answers in different areas. What I found that obviously I haven't done the operation before. That's not the area of my experience. But what I found in the texts is the right gastric and right gastrocoploic arteries. These are the one that's ligated. You will find different answers. This is the one I know. This is the one I'm going to say in the exam. Okay. In terms of the ligaments connecting with the spleen.
So you have the splenorenal ligament and the gastrosplenic ligaments.
Okay. And in this one, I'd like you to identify number 3 and number 9.
Number 3 is the head of the pancreas. Number 9 is the body of the pancreas.
Or maybe the neck, or yeah, you can say it's the body, but it's mainly, I think it's the neck of the pancreas. What is number 14 then? 1, 4.
3. 14 is the
Say again.
superior. Hello?
Yeah, say
Hello?
again. What is 14? I can hear you.
Superior mesenteric artery.
And what is 15?
The superior mesenteric vein.
Yeah, well done. Okay, so you have lots of other structures in here that we can comment on, but I think these are the main thing. 9 is the neck of the pancreas, 3 is the head of the pancreas, and 14 and 15 is SMA and SMV, and I think that's it really. Okay. All right, what is the blood supply of the urinary bladder?
The blood supply is the arterial blood supply is from the superior and inferior vesical arteries from the internal iliac artery. The venous drainage is from the vesical venous plexus into the internal iliac vein.
Okay, what is the nerve supply of the detrusor muscle?
We have sympathetic as well as parasympathetic. Sympathetic comes from L1 and L2, and parasympathetic from S2 to S4.
Yeah. What are the cancer type or the cancer types of the urinary bladder?
The most common one is transitional cell carcinoma, but we can have squamous cell carcinoma as well as adenocarcinoma.
Okay. Yeah, but transitional cell, the commonest of us, you have a squamous and adenocarcinoma as well. And what are the risk factors for bladder cancer?
Smoking, as well as certain types of dyes, as well as asbestos, as well, I think, in naphthalene, as well as an infection of schistosoma, as well as stones.
Stones as well. Yeah, well done. What's the peritoneal coverage of the urinary bladder?
it covers the superior surface and the upper part of the posterior surface.
Well done. Okay, what are the layers you go through in a suprapubic catheterization then?
With the skin, the subcutaneous tissue, scarpus fascia, linea alba, transversalis fascia, and peritoneal fat.
Yeah, well done. Well done. That's really good. In terms of the structures here, can you tell me what is number 39, which you can see here and you can see here as well. So just a trick for you. So basically, when you do the dissection, you inject some dye that's bluish in color into veins, and a transparent dye into arteries. So what do you think number 1 is? Number 1 is definitely an artery, right? And number 3 is
Yes,
an artery. 25 is an artery. 7 is an artery. So all of these are arteries. Okay. And number 8 and 23 and 4 and 8 on the other side, and 39 as well, that would be definitely veins. Okay, definitely veins. All right, so so 39 will be, or let's start by 23. 23 is
inferior vena cava.
okay, and you have a vein going to the inferior vena cava on the right side, but not going to the inferior vena cava on the left side. What do you think that is? Vein?
Yes.
Yeah, remember that we talked about,
Oh.
patients with left-sided renal carcinoma can get varicocele as well, and the reason why is the drainage of the left renal vein or gonadal vein go into the renal vein, right, and doesn't go into the inferior vena cava. Okay, 1 is the abdominal aorta. 3 and 3 is
3 is the common iliac arteries.
yeah, and 25 is
The internal iliac artery.
and 7 is
External iliac
good.
artery.
And yeah, what about 40 then?
I think that's the ureter.
Yeah, that's the ureter, right? It's going all the way down to number 2. And what is number 2?
The bladder.
Yeah, bladder. And as you can see, it enters in the trigon of the bladder into the superior lateral border or the posteromedial border of the base of the bladder, right? Superior lateral, as you can see here. All right, so that's a good diagram to, again, I personally like using these diagrams to study, really. Okay, so I would advise, when you're looking at it, okay, you can think what kind of questions that can be asked here. So you have also psoas muscle. You can be asked about the origin. So you would remind yourself that it's coming from the lumbar area and the thoracic area. You can talk about the ureter and its relation to the artery. I remember it's water under the bridge. So the ureter is the bridge, and you have the internal iliac artery just under it. Sorry, the external iliac artery. And also these are veins basically going all the way. So you can talk about the tributaries of the inferior vena cava. You can talk about the branches of the aorta. You can talk about how the ureter enter the bladder, as you can see here. So many things that you can use this diagram for. Another one that's very similar, but it's in a female patient. What is number 16?
Number 16. Wait. It's that the uterus. Yeah.
Yeah, that's the uterus. Yeah. And what is number 15 then?
Number 15. Bladder. Is it the bladder? No. I think that's the rectouterine pouch.
Or Douglas pouch, yeah. And what is number 18 then?
Number 18 is bladder.
Okay, and what's the space in between? 17?
It's the vesicouterine pouch.
Yeah, pouch. Yeah, well done. And what is the shiny structure that is number 7 on both sides?
Number 7.
The ovaries, right? That's the ovaries.
Yes,
Okay,
yes,
so
yeah.
the shiny structure. Again, you can use this diagram to say that 12 is an artery, 11 is the vein, that's inferior vena cava, 5 is the tributary of a vein, that's the common. I think the last thing we said is you can argue that here in this diagram, 12 is an artery, 11 is the vein, And you can talk about the ureter as well, going all the way down, which I think here will be number 2 on both sides. And like we said, the water under the bridge, you will have the ureter of the bridge, and then 6 is the common iliac artery, and obviously common iliac vein just under it as well. All right, so we'll to identify at what level is this section of the abdomen.
This is an axial cut of the abdomen, and this looks like it as at the level of lumbar vertebra 1, either lumbar vertebra 1 or lumbar vertebra 2, either of those.
Yeah.
Yes.
Okay, and are you able to tell me a few structures here starting by maybe number 17? Is here this one?
17 is the abdominal aorta.
And what about number 5 then?
5 is the inferior vena cava.
What about number 14? Is this 14? The one I'm pointing to?
Number 14 is the superior mesenteric vein.
And obviously it's inside a bigger structure that's green in color. Number 16 is?
Number 16 is the pancreas.
Well done. And what is number 2?
2
Okay.
is that's the superior pancreaticoduodenal artery.
I don't go that far because you're behind the first part of the duodenum, or the pylorus here. So that would be the gastroduodenal artery. The gastroduodenal artery, okay? Because you're behind the first part of the duodenum or the pyloric antrum. Does it make sense?
It's understood, yeah.
Yeah. Okay, what is 4?
4 is the second part of the duodenum.
No. So 4 is a space behind the first part, really. You're still in the first part.
Okay,
What's the
so
space behind the first part?
the lesser omen, the
Not
lesser.
yet the lesser sac. So the lesser sac is, you enter from here, and the lesser sac is there. This is the lesser sac.
Okay.
So this is the vestibule to the lesser sac, or the epiploic foramen.
Okay.
Okay. You have lots of other things in here. I think you have kidneys are pretty obvious. 7 is the coda equina, or the termination of the spinal cord. Obviously, this is the liver. 20, the spleen. And I think we identified the main structures, really, that usually come in the exam, but you can read the rest. Okay?